Hello, friends. Today we'll be discussing about tachycardia. Okay, how to deal with a patient presenting with tachycardia in our emergency department. Okay, first of all, like any other cases, we have to do check A, B, C, D, and E. Okay, A means airway. We have to check whether the patient is able to maintain the airway or the airway is patent or not. Okay, we have to check if the airway is patent or not. If the patient is able to talk able to talk, the airway is likely clear. And after that you have to also listen whether the stiter is present or not. Okay, if the chest is clear or not, you have to know about that. After that, you have to do breathing. Okay, test how to test breathing. Yes, is for rate and rhythm of breathing. Okay, rate, rhythm of breathing. Okay, and look for any sign of look for any sign of distress. Okay, look for any sign of distress, like use of accessory muscles. Okay, after this, you can also check spo2, whether spo2 is maintained or not. After checking airway and breathing, you have to check circulation. Okay, see for circulation. In circulation, what you do is check your pulse of the patient. Okay, pulse rate, rhythm of the pulse. Okay, and take blood pressure, possible in both hand. Okay, both hand if possible. And if not, for a very rapid assessment, you can also do a capillary refill. Okay, capillary refill time you can look. Okay, and by this you will have a rough idea about the circulation. Okay, what about disability and lastly exposure. Okay, disability, look for the level of consciousness of the patient, level of consciousness of the patient. Okay, if the patient is alert, if there is alert, the voice, look for the listen to the voice of the patient, if there is pain present or not. Okay, or the patient is unresponsive or responsive. Okay, unresponsive. Okay, and if possible, look for pupil reactivity as well. This is for disability, to know whether the patient has sustained any injury. Okay, to other part of the body. Exposure is like general assessment of the patient. I don't think this is mostly needed during the tachycardia assessment, but it's generally done during the emergency visit. Okay, after this, you have a general idea whether the patient is hypoxic or not, if the oxygen is not maintained, or if the bp is low. Okay, if, or this thing you should rapidly assess and provide. Like if spo2 is not maintained, okay, you have to provide oxygen and try to maintain spo2. If the bp is low, look for the sign of like why this patient is in shock. Okay, if there is hypovolemic shock or a bleeding or whether there is bleeding or whatever the might be cause. Okay, septic shock or any the type of shock, you have to do general assessment and provide the treatment accordingly. But for initially you might start with volume itself. Okay, to increase the volume, like giving any crystalloid solution like normal saline or renal lactate. Okay, you can provide this to increase the volume if needed, but you have to be cautious while increasing volume as well, because that might be the patient of heart failure or something like that. Be cautious, but you can always reassess in a few minutes. Okay, after that, yeah, after this you after this you open the iv line and send for some blood work. Okay, blood work to check for electrolyte. Okay, if you think the electrolyte abnormality might be the cause of tachycardia. Okay, and after this electrolyte and other baseline you can also send. Okay, after doing this much, okay, you have to know whether this patient has got life threatening tachycardia or not. Okay, life threatening tachycardia or not. life-threatening tachycardia, which is defined as if the patient is having shock. Okay, if the patient is in shock, whether there is a history of syncope or not. Okay, whether the patient is suffering from myocardial infarction or not. Okay, if there is typical type of chest pain. Okay, if there is ECG, by this time you have to do ECG as well. Okay, and if whether there is a sign of myocardial ischemia or not. Okay, sign of myocardial ischemia or not, or if you think like if there is any sign suggestive of severe heart failure. Okay, whether their previous echocardiography report, or if there is raised JPP or displaced cardiac apex, like that, suggestive of severe heart failure. If you think these four things are there, if the patient have these four things, then you have to give. If these are S, then you have to give synchronized DC cardioversion. Okay, you have to do the synchronized DC cardioversion. Okay, and up to, you can have three attempts to do this. Okay, and if you need sedation, you can give sedation as well. We generally give midazolam, or any benzodiazepine available in our center. Okay, you have to know your protocol of your center, and you have to give sedation before doing synchronized cardioversion because the patient is awake. Okay, and if unsuccessful, if that is not successful. Okay, if not successful, you can try amiodarone, and repeat synchronized cardioversion. If not amiodarone, and repeat cardioversion. Okay, repeat synchronized DC cardioversion. Okay, after that, if the patient, if these are not present. Okay, if these things are not present, if there is no, then you have to know the QRS complex of that patient. Okay, if the QRS is narrow. Okay, if narrow means less than 0.12 second. Okay, then we have to know whether this patient has got regular rhythm or irregular rhythm. Okay, QRS is irregular and narrow. That means the patient is in atrial fibrillation. Okay, atrial fibrillation, you can give beta blocker, or if you think the patient is a patient of heart failure, then you can give digoxin, or amiodarone itself. Okay, amiodarone. But for digoxin, you have to check. You have normal potassium should be normal. Okay, potassium should be normal before giving digoxin. You make sure your potassium is normal before giving digoxin. Okay, and along with that, you have to anticoagulate the patient according to the Charvas. Okay, there is something called Charvas. Okay, Charvas to score, and you have to coagulate the patient if needed, and if the AF is more than 48-hour duration. Okay, after that, if the rhythm is regular. Okay, if the rhythm is regular, this means the patient is having supraventricular tachycardia, which can be paroxysmal supraventricular tachycardia, or any other tachycardia that's above the ventricle. Okay, narrow complex regular tachycardia, you can try vagal maneuver. There are different type of vagal maneuver. You can try vagal maneuver. Okay, vagal maneuver. And if 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 the vagal maneuver not effective, then you can give adenosine. Okay, adenosine, IV adenosine, 6 mg. You can, if not effective, you can go 12 mg. Okay, after that, if the patient is not having narrow complex tachycardia, no. If that's wide complex or more than 0.1 to 5 second. Okay, then this means that there's a broad complex QRS. Okay, broad complex QRS, then again, it can be irregular or regular. Okay, irregular or regular. Okay, if there is broad complex QRS which is irregular, then it can be again AF. Okay, AF with our bundle branch block. Okay, with bundle branch block. Previously there was bundle branch block, and now the patient is suffering from atrial fibrillation. Okay. Or it can be polymorphic VT. Okay, polymorphic VT. You have to distinguish between them. And for AF you have to treat like we treated previously. Okay, beta blocker digoxin you can give in this case, while in polymorphicity, or also known as tosa in this case you have to give magnesium sulfate. Okay, 2 gram over 10 minutes. Okay, if the patient is suffering from a regular broad complex tachycardia, then it can be VT, or it can be SBT. Okay, I'll write this first. Okay, supraventricular tachycardia with bundle branch block. Okay, or it can be VT. If the patient is having SBT with bundle branch block, we treat the patient as a regular narrow complex tachycardia. We follow this algorithm. Okay, if the patient is suffering from VT, then we give amiodarone. Amiodarone, the usual dose is 300 mg IV over 10 minutes, and then we follow the different algorithm. If the rhythm do not rebound with this, or the patient in regular also, if that's not rebounded with adenosine, then we can always give synchronized DC cardioversion. Okay, up to 3 times, 3 attempts. Okay, and if needed we can give sedation, or if not reported with this synchronized cardioversion even after 3 attempts, you can try drugs like amiodarone again and try synchronized cardioversion again. Okay, I'll stop here only.